I'm Mike Royer with an extended interview in this Health Matters Web Extra. Welcome into this edition of Health Matters. We're joined today by Dr. John McDonald, OBGYN, and currently the interim chair of that department at UMC. Dr. McDonald, it's good to see you again.
Thank you, Mike. It's good to be here.
We do a lot of segments about health issues that affects every person watching, but we're focused today on women and an issue that women unfortunately have to deal with once in a while called endometriosis. And those of us who have wives or mothers or others who have dealt with that know a little bit about it, but let's start with the basic definition of it, what it is.
Endometriosis is a condition where endometrial tissue that normally is a part of the menstrual cycle each month, instead of coming out of the body, it actually goes back within the body and it settles into the pelvic area and creates a condition where patients most commonly during their period will encounter extreme bouts of pain.
And is this more likely to affect young women, middle-aged women, child-producing age women? What's the general thinking on that?
The general consensus is that about 5 to 10% of women of reproductive age encounter problems with endometriosis. That number goes up into the high 60s and 70% though for women that have chronic pelvic pain. So in other words, they have pain throughout the year. So it primarily affects young and middle-aged women.
So if a woman's menstrual cycle operates the way it was designed to do, all or nearly all of the blood that normally would be a part of that process leaves the body, but this stays, and then does it clot like we would think of blood not being used, would clot and harden, or what happens to it?
What happens is the endometrial tissue actually settles into the structures in the pelvis, which are primarily the bladder, the rectum, the colon, the ovaries, and the fallopian tubes. And it creates an inflammatory process that creates a cascade of issues similar to when you get a cold. And so that you have painful stimuli of the nerves primarily in the pelvis, and that is what really creates the devastating pain that some women experience.
And you use the word devastating, you're not exaggerating. All of those places you said where it could be affected, any one of those could be extremely painful if this continues for too long.
Absolutely.
So what do you do about it as an OBGYN? When you spot this early on, is there a way to combat it, treat it, or do you have to do some sort of invasive operation?
Well, as a physician, we first want to ask the appropriate questions to determine whether or not it may or may not be endometriosis. And your physician may ask questions like, when does the pain start? Does it come and go? Is it associated with your menstrual period? Does it last after your menstrual period? And what types of pain are you having? Is it achy? Is it sharp? Is it stabby? Does anything make it better or worse? And from that, you can make a clinical diagnosis. The gold standard diagnostic test, though, unfortunately, is a laparoscopy, where you place a camera inside the abdomen and you look around. And someone that has endometriosis will have, for lack of a better term, they call them powder keg lesions. So you look at different structures in the abdomen and you'll see almost like cigarette burns. That's what it looks like grossly. And if you see that on laparoscopy, the good thing is that you can actually excise it. You can take it out, and that oftentimes helps women immensely.
Are you able to do that when you're doing the laparoscopy? Is it, if I said
Yes,
that
sir.
correctly?
That's right.
So you're not only looking, you can possibly help this woman while you're there.
Absolutely, and that is really the major advantage to undergoing a surgery for this. It seems extreme to do that, but the data is well calculated on this issue. Operative laparoscopy is not only the gold standard for diagnosing it, but also excision and ablation of the lesions is good.
One more question on this. When you do that examination with the camera, does that require an incision, or do you do that vaginally?
Yes, it is a small incision in the umbilicus that's about 1 centimeter in length. So it's pretty well hidden in your belly button, and it doesn't require extensive skin incisions for that.
Any preventative thing women can do to avoid this, or if it's going to happen, it's probably just going to happen?
There's really nothing that can prevent it, unfortunately. There are some studies that talk about a genetic predisposition. We do know that white and Asian Americans have a heavier predisposition for endometriosis, and African Americans actually have a reduced incidence of it. And there's really nothing you can do. However, in our clinic, a lot of our ladies do not want to undergo surgery, so there are some pretty effective medical managements for this. And to understand the medical treatments, you have to understand that what feeds endometriosis is estrogen. Estrogen is produced by the ovaries primarily, so if we can give patients a medicine that reduces the amount of estrogen in their body, that will actually alleviate the symptoms. And the most common one that we use is a birth control pill. Birth control pills reduce the amount of estrogen, and a lot of times it provides symptomatic relief without having to undergo surgery.
Once women reach a menopausal period or even postmenopausal, would this no longer be an issue? The originating problem would not be operating anymore. Is that an oversimplification?
You're exactly right, Mike. Okay. When a lady goes through menopause, the ovaries quit working, and so their estrogen levels go down. And so what is feeding the endometriosis goes away, and oftentimes the pain from endometriosis does resolve with menopause.
Let's end with this guidance from you. Like any physical ailment, ignoring it is the worst thing you can do. If a woman is experiencing discomfort in her pelvic area, stomach, anywhere, don't just wait for it to go away. If it persists at all, you need to see your OBGYN as soon as you can.
It's always a good idea, Mike, to consult with a physician, because sometimes it can be things other than endometriosis. Yeah. It could be some type of other pelvic pathology that may need attention.
Dr. McDonald, thank you so much. We learn a lot talking to you. That's the point of our segment, of course. So we appreciate your time today. Thank you very much.
Thank you, Mike.